Hi, Dr. Devos.
Hi, Felix. Welcome.
So sorry, having some technical issues there. Sorry about that.
No problem, no problem.
How are
So
you?
first, welcome all the viewers already online. Thank you for the questions in the chat box. We're starting off with some pre-submitted or pre-prepared questions, and then we'll take those in the chat box. So let's keep them coming.
Brilliant.
All right. So I made some improvements in my technical skills. So I put up the YouTube chat box on the screen while we're doing this. This makes things much easier. All right. So first question. So Felix, you're advanced clinical practitioner in the UK. So for all the people that don't know you yet, that haven't seen the videos with you in it yet, maybe shortly introduce yourself.
Sure. Yeah. Hi, everyone. I'm Felix. I'm an advanced clinical practitioner working in hormone replacement medicine at a private clinic called Healand, based in Leicester in the UK. We cater for male hormone replacement and female, and we use various sort of modalities of treatment, whatever will work best for the patients that we see. We also have other branches of therapy, such as peptide therapy, and also psychotherapy and chronic pain management as well.
Awesome. So the first question we had for you was, how do you manage water retention or edema on TRT?
Right. Yeah. So this is an interesting one, and people worry about it a lot, don't they? You see that a lot in posts in your group on Facebook, and I think that the key thing we need to think about is not sort of rushing straight in to manage it, but asking ourselves the question, why is it happening? So it's very commonly seen when we first commence TRT. And I think a lot of people worry about estradiol being the culprit. And it's more than often not the case. So when we think about how our bodies respond to exogenous testosterone use, we see that impact at the very beginning of treatment mostly. And it does tend to be transitory and settle, but it's more often than not, I think it's not to do with estradiol per se. It's more to do with our sort of sodium regulation hormones. So with the main ones being renin and aldosterone, because you do see an upregulation in aldosterone when you first commence TRT, and that's because if I could work out how to share screens with you, I could show you them in the steroidogenesis cascade diagram that I've got. But essentially, you can all go and Google that. But you've got multiple arms of cross conversion when you're thinking about steroidogenesis. So it's not just about our sex hormones, our male androgen hormones, and estradiol and progesterone and things like that, and pregnenolone and allopregnenolone. You've got cross conversion arms, and one of those is the mineralocorticoid arm. Now that's what regulates our fluid. And the main one being aldosterone, with obviously renin coming into play as well, because our kidneys are what control all of our fluid regulation in the body, and that in turn controls our blood pressure. So when you first start TRT, you do see a bit of an increase in aldosterone, and that will lead to a little bit of water retention. You'll see people most commonly posting about it either sort of peripherally, so ankles, feet, things like that, and also sort of around the face. They get that puffy sort of red face look. Now, as I said, it does tend to settle by itself. So I think in terms of management, I don't rush in. I tend to reassure. So clinically, I'll say this is expected. And the main thing being, we need to think about whether this is clinically impacting people. So by that, I mean, obviously, you see it. It's a bit unsightly. You don't like the look of it as a patient. But the reassurance that it is temporary, tends to put most guys' minds at rest. But the clinical thing we need to think about is it impacting our blood pressure? Like, so if you've got, for example, guys with a history of congestive heart failure, or they've got a history of anabolic steroid use, and they already have some sort of cardiac remodeling or left ventricular hypertrophy, then yeah, you need to probably take those case by case basis and think to yourself, this deserves a little bit more exploration. So I think in terms of management, you don't need to rush in, and I certainly am not a big fan of using any kind of antidiuretic medication, because again, we're just sort of treating a symptom rather than looking at a cause, and the cause is often very temporary. Now, like thinking about if you were to, like, so a lot of people will hammer the estradiol thing when they and say no, it's definitely this, because the physiological mechanism of estradiol, which I might add is actually, in terms of our data, is mostly derived from female studies, which, you know, when you think about their levels of estradiol, they are in no way comparable to even some of the highest levels you see of guys on TRT. But from a physiological perspective, estradiol, the reason people worry is because it does alter the set point for osmoregulation of arginine vasopressin, which can increase your plasma volume, which then makes people worry about increased blood pressure. Now, that hormone, or we'll call it AVP because it's a bit of a mouthful, is actually our primary hormone that's involved in the regulation of renal-free water. But as I've mentioned already, it does also affect our sodium regulation hormones like aldosterone and renin. Now, interestingly, when you look at the data for women, and we need to remember these are very high levels of estradiol in these women, the clinical effects or alterations in their physiology are seen to be very minimal. So jumping on this bandwagon and saying that estradiol is causing this fluid retention and this is something that we must worry about and we need to hammer that number down because you've seen one clinical symptom of, say, slightly puffy ankles or a bit of a puffy face in the first few months on TRT, doesn't make logical sense to me. And interestingly, even in these studies on women, it doesn't actually increase the risk of deleterious cardiovascular events, having these high levels that do cause these clinical alterations like peripheral edema and sort of some puffiness of the face. So if it's not impacting your blood pressure as a male patient and the number is, in no way comparable to these massive levels you see in women, then I don't think if comorbidities aside, so congestive heart failure and other cardiac things, then yeah, you need to take a bit of a measured approach working with their teams, because they'll be under people that look after that side of things anyway. Then you don't need to worry too much. But if you were really wanting to look at doing something, if that reassurance for your patient hasn't had as big an impact as you would have liked, then you can think about other things like vitamin B6 supplementation, magnesium. So sort of, in the higher dosing regimens, more than you need to see anybody sort of recommending, can temporarily, you wouldn't want to keep them on this long term, have an impact on reducing this sort of fluid retention. So things like magnesium, you'd be looking at sort of what they've studied in the literature is sort of 600 milligrams plus, things like that. And then the obvious ones, like keep hydrated, keep your electrolyte balance going, flush those kidneys through, because don't over consume protein, because that's a big one that we do. We're all guilty of doing that. Most guys that are on TRT do like to keep physically active and fit and do quite a bit of resistance training. Now that increases your creatinine, and you want to make sure that your kidney clearance times, which can be studied via things like EGFR, estimated glomerular filtration rate, or cystatin C is a bit more accurate, is actually allowing you to clear that creatinine adequately. Because what you don't want over time, if you're over consuming protein and not hydrating and on TRT, is to give yourself a slow burn chronic kidney injury, which can occur. But those are sort of in extreme circumstances. You've got to be eating sort of 200 to 300 milligrams of protein, 200 to 300 grams of protein a day to be doing that kind of stuff. And that's IFBB style stuff. Like, that's not, your average guy's not going to be doing that. So I think, to summarize, it's not something that we need to jump on and actively manage. But if you did want to do that, then start with the basics. So look at keeping well hydrated, perhaps supplement with vitamin B6 and magnesium high dosage.
Yeah, awesome. The other one. Yeah, what is the level of free testosterone most men are optimized on?
Oh, right. Yeah. Wow. Yeah. That's a big one, isn't it? So essentially, that's how long is a piece of string. So you'll get some guys, and it's got to be patient centric, hasn't it? You'll get some guys that are optimized on. I'm going to speak in UK terms here, but you'll get some guys that are optimized on maybe a 0.5 nanomoles per liter free T, and then some guys that need a 1.5. Now, what we need to bear in mind is when we're getting towards those more sort of much higher levels, so sort of 2 to 3 nanomoles per liter plus, you're entering sort of supraphysiological territory. Now, whilst that may make you feel absolutely great for a period of time, chronically over the years, that there is some data to support that does, because we have to remember testosterone is an anabolic hormone. It's responsible for growth of cells. there is some evidence of cardiac remodeling, like so, and the most common form being left ventricular hypertrophy. So if you are one of those guys that requires a little bit of a higher free testosterone level, that's all well and good, as long as your clinician that's managing you is aware of the risks of being at that level and is actively monitoring you and ensuring your safety. But like I said, you won't find many guys that are going to be needing sort of 2 to 3 nanomoles per liter free testosterone. Usually in my clinical experience, sort of anywhere between sort of 0.8 and 1.2 to 1.5 nanomoles per liter, most guys tend to feel pretty good on. Now, if you start getting other sort of side effects like increased erythropoietin production, which can be a side effect of having a free test level that's higher, and that's raising your hematocrit. I mean, this is a can of worms, isn't it? you don't really, for me personally, excuse me, I don't worry too much about hematocrit as a number, because secondary erythrocytosis, secondary to being on TRT, isn't actually is well studied, and it isn't actually a massive risk factor for deleterious cardiovascular outcomes. Now, having said that, like I said before, you've got to think about those guys that have a cardiac history. If they're raising it and their BP skyrocketing despite being on antihypertensives, then yeah, you need to sort of look a bit more closely at that. But as a general rule, if your free T level is high enough to be sort of pushing your hematocrit up, but your hematocrit number is you know, so let's say it's 0.6, for example, but it's causing no clinical issues, like you're not getting raised blood pressure, it's causing no fatigue, you're not getting breathless, then this is well supported in the literature. Secondary erythrocytosis to TRT isn't a risk factor for deleterious cardiovascular outcomes. It's more the fact that high free test level is causing over time, and we're talking years here, like many years, is likely to put you at increased risk of cardiac remodeling. Like so, I think you know, we in terms of what number is the best, it's whatever feels good for you as a patient, and that needs to be agreed and monitored between you and your clinician.
Sure. Yeah, what is your approach if one is going to start TRT but might later on want to have children? Freeze sperm in advance, and what fertility protocol do you use?
Okay, yeah. So this is actually a question that I ask all of my guys that are, you know, less than 40, because most of the time, by the time we've got to 40 as a guy, you've probably thought about, or maybe already have children. Not always the case, but one of my first questions when I'm doing my initial consultations is, do you have plans for family, or do you have children already? Now, if they don't have children, but they do have plans for family in the future, then I obviously counsel them on the fact that TRT monotherapy in particular will cause a shutdown of fertility due to the break in the hypothalamic pituitary gonadal axis, or the suppression of that. And this is something that I don't labor too much. You see people hammering it, like going, oh, you know, using it as like a sort of a stick waving thing, like saying it will make you infertile, and sort of almost threatening guys. And you see it on social media, actually. I know Dr. Winge that you spoke with recently just did a sort of a breakdown of an American doctor that was saying all that stuff, like Dr. Mike, I think his name was. And yes, it does. But what that isn't supposed to be used as is a scaremongering tactic, because these things are actually easily managed. Now, there are a number of ways we can preserve fertility. Now, the intercurrent use of human chorionic gonadotropin, or HCG, is a way of doing it, and it's a way that you do see a lot of people doing it. You can use other things like selective estrogen receptor modulators, like or SERMs, they're more commonly known as, like Clomid or Nolvadex and things like that, to try and keep that pituitary function going, because it's the combination of follicle stimulating hormone and luteinizing hormone mimicry via HCG that will continue to stimulate the Leydig cells in your testicles to produce intratesticular testosterone. And without that, you can't actually produce or finish the production of sperm. Myself, clinically, I don't labor this sort of like, you must have, if you want children in the future, you must have HCG, because you know, I've seen guys on TRT monotherapy have children. So it's, you know, it's not an effective contraceptive. Like, just remember that, guys. So you know, I don't think you need to hammer it at home saying you must use. And I'm certainly not a fan of starting people immediately on HCG and testosterone at the same time. because I think that's something that if you want to add it in to see if it adds benefits to their therapy, it's hard to do that when you started it from the beginning. And if they have negative treatment effects, you don't really know which one was doing what. But yeah, certainly theoretically, there is some evidence that HCG use intercurrently with testosterone will or can contribute to preserving fertility. But I think it needs more study, because I don't think it's as simple as how I've broken it down. I think there's a massive interaction with the CAMP messenger system, or cyclic adenosine monophosphate, and how that interacts with dopamine, and then so on and so forth. I know Dave Lee's he's a big fan of the neurosteroid sort of synthesis pathways, and we could talk for hours with him about that. But myself personally, if a guy wants to start TRT monotherapy but does have plans for family, I will tell him about the option of HCG intercurrently, but I will also say that we can actually use other means. So you can use things like recombinant FSH, which is injectable. There's brand names such as Gonal-F, which is like follistatin, which is interestingly, a bit of pub trivia, is derived from the ovaries of hamsters. Yeah, not a lot of people seem to know that. So it's something to bear in mind, especially where I work, where there's large religious communities that maybe don't tolerate sort of animal products. But you can use large doses of that, and you can intercurrently use other SERMs like raloxifene as well is an effective one, because it has a slightly different activity pathway to Clomid and Nolvadex or tamoxifen. So yeah, there are lots of ways we can do it, and you don't have to be on HCG from the off in order to so-called preserve fertility. Yes, it will have a contributing factor to that, and I have seen that clinically. But I have also seen, like I said, guys on TRT monotherapy father children, and I've also seen guys using our specific fertility protocol that we do at Healand, which is a proprietary thing that I'm not allowed to say the details of, unfortunately, that have also gone on to father children. So it's there's more than one way to skin a cat when it comes to thinking about having children in the future when you're on TRT, and it shouldn't be something that should put guys off TRT that need it.
Yeah, agree. Is microdosing every day a good TRT protocol, or is doing it 2 or 3 times a week just as well?
Yeah, so this is an interesting one. I've actually just done a whole series of videos on this, and dosing intervals. So when we say, is it a good protocol, what we need to, I suppose, think about is that achieving symptom resolution for our patients? So you can, if you want to measure it as an arbitrary number, it keeps my total and my free T within this range, you need to marry that up with how that makes your patient feel. So, if you're, for example, using everyday subcutaneous injections of a medium chain ester like testosterone cypionate or an anthate, and that's working well for your patient, and they feel like their symptoms are alleviated, and they are staying with outside of supraphysiological ranges, then yeah, go for it. But if you've got a guy that responds better to either every other day injections or even Monday, Wednesday, Friday, then there's an argument to be made that TRT is about alleviating, not just about thinking about numbers, but alleviating negative qualitative symptoms. And that's something I think that gets forgotten a little bit, because you see a lot of clinicians focusing on, it needs to be in this range of numbers, and we just need to concentrate on that, and we need to make sure their SHBG is this and not falling or rising too high. And then they get obsessed with that. But what they're failing there is their patient. They're basically saying, it doesn't matter about how you feel, when actually the whole reason you came to get TRT in the first place is the first thing you noticed you didn't feel good. So I think it's very patient dependent. So I'm very open to seeing how guys go, because it's a mental burden. I think when you've never injected yourself before, even with a 29 gauge insulin pin, to inject yourself every day, and thinking about it as 3 times a week is a lot from a cognitive point of view, a lot less of a burden to you when you've never injected yourself before. And it may be that you respond very well to that, and you might like the sort of temporary peaks and troughs that you get from having a 3 times per week injection protocol. Now, on that note, I suppose you can't mention that without talking about hormonal stability, and that's an interesting one, and I go into it in the videos which are coming out soon on our channel at Healing Clinic on YouTube. And I've used a calculator to show the pharmacokinetic profiles of these different esters of testosterone and how they peak and trough. Now, when we think about natural guys who have normally healthy levels of testosterone, we see that diurnal variance, don't we? We have a bit of a spike in the morning when we wake up, and then we have these little mini peaks and troughs as we go throughout the day. Towards the evening, we start to go down a little bit. And, the working theory of that, if you look at the data, is that as our testosterone levels start to decline in the evening, that's setting us up for rest and repair when we go to sleep, and our cortisol levels should follow. Although there's an argument to be made in this day and age, we're constantly stressed, so we're constantly having high cortisol regardless of what our testosterone is doing, but that's a whole other debate. But theoretically, that's what we should try and mimic, shouldn't we? So a lot of people jump on this sort of to doing the microdosing every day because it very closely mimics that diurnal variation. What it doesn't do is give us that spike in the morning. Like it's because once you're stable on daily injections of a medium chain ester like cypionate or enanthate, you just have this constant line. And this is demonstrated in the graphs that I've done. And I'll share links with the community about that when I've published those. But yeah, it's an interesting one. So in terms of what is the best, or is it good, that has to again be about what your patient is feeling. So does your patient feel good on daily injections? Do they prefer a little bit of a boost, having a 2-day break in between? Because they might. Is there room for looking at mixed proprietary blends? I spoke with a very interesting doctor in the States back in July who utilizes a mixture of doing every other day injections, but changing between cypionate and propionate. I've yet to plumb that into the calculator that I was using, but it would be very interesting to see if that more accurately mimics our natural diurnal rhythm of testosterone synthesis. But yeah, in terms of is it good, it can be. But there are also other ways to do it. You don't even have to inject. Like there are some very good cream protocols. You've got really good things like Versa-based creams now that can be either prepared on inner thigh or inner arm, even transscrotally. Interestingly, but another bit of pub trivia. Back in the early 1980s, one of the first preparations of TRT was transscrotal adherent patches. Now, obviously, that had lots of ramifications for comfort with guys because it meant that you had to be shaved on your scrotum at all times unless you wanted to be in a lot of pain changing your patch because it was an adhesive patch. So, but it saw very good results and it fell out of favor because of how uncomfortable it was. But it's funny how I think things go full circle. We're looking more at sort of transscrotal creams nowadays that provide a very good symptom alleviation whilst ensuring appropriate levels for people.
Great, thanks.
No worries.
All right. Yeah, I recently made a video about this, but anyway, the same question is back because it's in the UK. So in the UK, most testosterone, like Sustanon, comes in 1 milliliter glass ampules that people have to break open each time. So the question was how to split and store that testosterone for later injections. I know a lot of people are keeping them into the 1 milliliter insulin syringes, and there's also the option of bigger 10 cc glass vials like they have in the United States. So what do you propose to your patients?
Yeah, so I'm more of an advocate of storing medications in glass just because that's been studied better. And we have to ensure that those vials are meeting the correct ISO standards. So by that is how they're produced in a sterile environment so that we know there's nothing in there that contaminate our testosterone because we tend to keep it for a fair while. So we, in terms of my preference, I will always suggest things like this. So this is an ISO standard glass vial. That's a 10 ml one. You can get them in 5 and 2.5 mils as well. But they are, because of the way that they are manufactured, they are very expensive and they're also prescription only. So I wouldn't recommend going on any kind of other website and just going, oh, that looks the same and getting it, because they may say that it's completely sterile inside. But I've seen some absolutely horrendous sort of losses of muscle from quad injections from contaminated vials and things. So yeah, I actually saw one patient in the past that lost half of their glute. So I would, if you're going to go down the route of storing it for multiple dosage use or using it as a multi-dose vial, then I would do that through your clinical provider. I certainly think that there's and I've done a test with this. I've left testosterone in a slim pin for 2 months, and then the rubber bung does break down eventually, and you see very small bits in there. And I'm just not, whilst that probably doesn't have a massive physiological impact, I'm not a big fan of putting plastic into my body. So either intramuscular or subcutaneous, and certainly, you would never use it intravenously in TRT. But yeah, I think anytime you're using a needle near vessels, any bits of sort of rubber or plastic is a no-go from me. So I think preference-wise, it would be glass. But we do also have the option with the pharmacies we specifically use at Healand, where it arrives in a 10 ml multi-dose vial. So there's brands like Perigo that will do your test sip at 200 milligrams per mil, and it comes to you as the patient in its multi-use vial. So yeah, but if you have something like Sust or Enanthate that comes in the glass ampules, then yeah, for sure, if you're going to multi-dose, I would definitely recommend using something like this.
Great. One more pre-prepared question that I had. Oh no, that was it.
Okay.
All right, so let's go to the chat box. So
Okay.
for everyone still watching, please let the questions come. All right. Somebody said, I started TRT in January 2022. My blood work seems good, but my PSA went from 0.87 to range of 1.5. Is that something that I should be worried about? Yeah, and I did notice a big 6 drive.
Okay. So this depends on age, because the range of what is considered acceptable upper ranges for PSA, by the way, is prostate-specific antigen, and it's a marker for prostate growth. So 2 things. It depends how old this patient is, because in guys between sort of 30 and 60, up to 4 is absolutely fine. So 1.5 I wouldn't be concerned with. And it depends whether they had symptoms before of things like BPH or benign prostatic hypertrophy, or whether they've developed symptoms since. So I would recommend that if you're having any lower urinary tract symptoms, and you've seen an increase in your PSA, then having a chat with your clinician who provides your TRT, who would probably want to do something called a DRE, which is a digital rectal exam, which unfortunately is a gloved finger in the rectum to check the size of the prostate. And then at least you've got a baseline for how big it is at that point in time. And then at your annual reviews, if your PSA continues to rise or your symptoms increase, then they know that it's getting bigger than the last time they examined you. So if it's not something you've had done and you've seen a rise in your PSA, I would probably chat that through with your TRT provider.
Sure. But it's kind of normal that the PSA goes up once you start on TRT, at least a little bit.
A little bit. And like I said, if this is a younger gentleman, then, 1.5, I would not even bat an eyelid at. Like 0.78 to 1.5, yeah, I wouldn't worry too much. But it does need to be something that, because I don't have all of their clinical information, like it would be something that has to be reviewed in context by the person in charge of their care. But yeah, generally speaking, not too worried about that.
Sure. What is a good TRT company to go with? That's a general question.
Really? In the UK, or are they? Yeah. So we're I mean, depending, if you're talking about the UK, then we're actually fairly limited. Like there's not that many clinics. I think probably a few more than in Belgium. So I remember the last time we spoke, it seems to be very underserved there. Yeah. But obviously, I'm going to say that Healing Clinic is a great place to come. So because I will do my best to work with you as the patient to find what works for you. Like I've got a gentleman at the moment who's just really not getting on with injections. So we're exploring the avenues of topical applications and looking at Versa-based transscrotal creams. So yeah, it's it depends. You can get these people that are like stalwartly, injectable is the way to go, and that's probably just because what they're comfortable with. But like I said, I'm more about working with the patient. There are other options in the UK. It's off the top of my head, I can't actually think of their names, but there's a few big ones that seem to come up on my targeted advertising, just because I work in the arena. But yeah, if you just Google it, you'll find it. But Healing Clinic is it provides home blood service. We ask it to see you once in a year, and then we'll do the rest of your follow-ups via remote. So yeah, there's lots of options. I think there's probably about 5 serious TRT clinics in the UK. if I had to count. But yeah, a simple Google search of them, you'll find them come up on the map, with Healing being based right in the middle of the UK in Leicester.
Right. And if you're not in the UK, go into our Facebook group, TRT and Hormone Optimization, post your question there, and surely you get an answer from someone in the US, in Australia, and so on.
That's it. Yeah. Dave will chime in. Jordan will get in there. Gil as well. Like, great.
Sure thing. Someone will find and help you.
They will.
Ethan Eisenberg said, I hate the urological and endocrinologist guidelines regarding TRT. They act like it's set in stone, and they're so conceited about it. Why is this?
Yeah, so I guess it depends what country you're hailing from, but it's I think it's similar everywhere, isn't it? So so here we have the British Society and the European Society for Sexual Medicine guidelines. And yeah, they are specifically about the numbers. They do mention qualitative symptoms, and they have like this thing that I find quite amusing, where it's like they're being generous to these guys. They're like, if he's 12 nanomoles and feeling symptoms, then maybe consider a trial. It's like, oh, that's very good of you. But then they have like this other number. If free T is below 0.220, definitely start. And then, interestingly, the algorithm in the UK for the BSSM says, although if he wants children, don't start TRT, just give him high dose HCG, and it goes off on another algorithm on this flowchart. So it's something, I think, to answer this guy's question. It's something that I think is designed as a generic guidance for people that are overworked and under-resourced. And by that, I mean primary care physicians. So these men and women who are working as general practitioners in the UK especially, they get about 6 to 10 minutes to see a patient and think about all the differential diagnoses it could be, and then make a decision and maybe write a prescription. Now, if you're trying to think about whether the person in front of you is testosterone deficient, you need something that is a simple flow diagram that tells you numbers. Now, as a GP, it's easier for your cognitive workload when you're seeing 30 patients a day and getting 6 to 10 minutes to do that, to go, it's not this number, so I'm sorry. Like, and that's very efficient for them, and it's not nice for the patient. Certainly not the best practice, but I do sympathize with them because they are massively overworked and they don't get a lot of education on how hypogonadism works or what it even is. There's doctors in my family, and they tell me they got told nothing about it at medical school. I don't know what it was like for yourself when you were at medical school, but like they labor a lot about female hormone replacement, but they don't talk at all about male hormone replacement, other than mentioning that it's probably secondary to anabolic steroid abuse, which is, these are words given to me by a medical student I was there, because I also work in A&E as well, that told me at A&E that that's what they got told. So
yeah, still same here in Belgium.
Yeah,
it's
not right.
Yeah, the course endocrinology is all about thyroid, diabetes, a little bit of sex hormones, but not too much, and certainly nothing about TRT. So
and if they do know anything about TRT, they will just say, here's some Nebido or testosterone endocannulator, and say, we'll jab you every 12 weeks, which is it's the worst protocol ever.
Simon von Sprecher, how bad is it to store testosterone enanthate close to or slightly above 30 degrees Celsius? As in, how fast will it lose effectiveness and can no longer be used?
Yeah, so that's an interesting one. So I actually approached a manufacturer of cypionate, which on a molecular basis is very similar to enanthate. So I think it's probably transferable. Because I was having issues with the cypionate crystallizing, which is quite a common issue if you transfer it into another vial, like one of these, out of its glass ampule. And they said it has a good tolerance for high temperature, but a poor tolerance for low temperature in terms of its structural stability on a molecular level. So they said you're okay to put it in hot water to re-emulsify the testosterone into the oil so that it becomes injectable again, and it won't have an impact on it. So yeah, I think in answer to the question, it has a good tolerance for high temperature, enanthate and cypionate. As far as the other esters go, I haven't inquired, but I would imagine it's fairly similar, but they are molecularly slightly different. So I would definitely inquire with the manufacturer. But yeah, I think for enanthate, it's perfectly safe to store it slightly higher. I actually store my own on a reptile heat mat to prevent crystallization, because in the UK, It gets very cold in the winter, and I store my my test in a safe to keep it away from my children. And I've come to it before where the temperatures drop rapidly overnight, and it's just crystallized and it's just solid. So, but since I started storing it at 27 degrees on a reptile heat mat, like the kind that you use for keeping snakes or lizards,
Yeah.
I've never had the issue ever. So
that's reassuring. Okay.
Yeah. And you know, my levels have been perfect. So it's yeah, I don't think it's an issue.
Do you have any tips for the best injection sites for daily injections? I've been using DELT and alternating daily. I'm already getting some signs of skin thickening.
Yeah. So you're gonna get whenever you're doing daily injections, regardless of whether it's shallow IM, subcutaneous, you're gonna need to rotate your sites. But you will, on a lifelong therapy, if you're going to be on this forever, your lipodystrophy, which is the thickening that he's talking about, or more specifically lipohypertrophy, is unavoidable. Right. So what the best way that you can do that is by rotating your injection sites and using muscle massage. So those Theraguns are quite good for trying to keep that minimal. But yeah, it's something that only rotating sites will help with, I think.
Right. Yeah, coming back to the fertility protocol, how long do you traditionally wait before introducing HCG into the protocol?
Yeah, so it depends how you're going to do it. So if I speak to a guy and he says, I want to make a good run at this in terms of attempting to have children with my partner, and they volunteer that they want to come off, then you stop the testosterone therapy, and then you can immediately commence them on the what we call it healing, the medical restart protocol. And that's a combination of different drugs, and you can do that straight away. Because it's not so much about wanting the testosterone to wash out of your system, because you need testosterone to be fertile. Excuse me. It's about stimulating that FSH production, and that happens very rapidly utilizing either high dose HCG, or I'm actually more of a fan of HMG, which common brand name is things like Menopure. But you can use just recombinant FSH like Gonal-F or Follistatin to the same measure. And I've actually seen higher levels of FSH, or certainly quicker spikes in FSH using Follistatin. So.
Right. Another question was just coming in. What's the typical dose for HCG a week? I've currently been dosing 500 IUs twice a week, but I only noticed the sexual benefits for only 24 hours post-injection.
Yeah. So I guess if he sounds like he's bolus dosing 500 units at a time, so you're gonna see some increased libido there doing it like that. So you know, I guess it depends what your goal of using HCG is. If it's purely for enhanced libido, there is going to be a point at which you have auto regulation, so your body will become used to that level. I wouldn't recommend continually upping the dose, because there's going to be a threshold you hit where you get more negative treatment effects than the positive outcomes you're searching for. But you can split up the dose, and to answer his question, the average dose that most guys have is around 750 units a week on TRT in the UK. But yeah, 1,000 is not outside the realms of, you know, madness or anything like that. It's acceptable. But yeah, if it sounds like he might be using it just for libido enhancement, and that's probably not the best use of HCG, because at long term it's not gonna work. If you're having real issues with your libido, then we maybe need to look at adjusting your protocol in terms of your test dose or other factors in your lifestyle, because libido is such a complex area, and it's not just about your hormone levels. They certainly play a key part, but in terms of psychology and how society impacts our viewers, men on TRT, that can impact your libido. So yeah, it's complex. So if you're just using it for that, then yeah, 1,000 units is okay. I probably wouldn't bolus it into 500 unit doses. I'd probably split them every other day just to get that, because what you're looking for, or if you're trying to enhance your libido, is a change in your state. Like, so you're going to get that better if you do it sort of every other day. You're going to get smaller impacts, but you'll probably feel it for longer before you reach that point where you auto-regulate and don't feel it effects at all.
Right. Bakr Ali, you've posted the same question we've already answered about your PSA going up. So you've already answered that. If you missed that, go back and rewatch. Someone else says, I'm 43 years old, overweight, total testosterone 17 nanograms per deciliter, free testosterone 1.6 picograms per milliliter, currently on 40.5 milligrams gel a day for 2 months now, and haven't felt or seen any difference yet. Any suggestions for me? And he adds, I'm also type 2 diabetic on metformin and Ozempic. My AC1 is approximately 5.3% now.
Okay. Yeah. So first recommendation: don't use gel. so gel is not a great modality of treatment for TRT. It's an unbound form of testosterone that has a very short half-life. So you'd have to make gel effective would make your life very inconvenient. You'd have to be applying it every 1 to 2 hours, which is just insane. Yeah, I would definitely change the modality of treatment. Have a chat with your provider about looking at alternative options of therapy. Be that transscrotal creams, because you can use those quite effectively just twice a day. And in fact, there's a very good ebook I think that you've made yourself. Have a look at Dr. Devos's ebook on testosterone cream. It's very good. And have a chat with them about that if you're not keen on injecting. So I think it's odd that he's on gel in this day and age, and that might be because he's averse to injections, and that's perfectly okay. No, nobody really likes stabbing themselves, so it's a good way of ensuring accuracy and precision with dosaging, but it's not the only way to do therapy. But yeah, I would definitely bin that gel and chat with your provider about looking at a different mode of treatment.
Yeah, sure thing. What are your thoughts on any SARM, selective androgen receptor modulators, that help with PSA?
Yeah, so I mean, this is a difficult one, isn't it? So these are unregulated research chemicals. So I would probably not recommend that you dabble in those, because there's other more tried and tested methods of, and it was PSA he said he wanted to influence. There's definitely better medications out there that are tried and tested and meta-analyzed to show better relief with a known safety profile, and that's the key. So if you're looking at research chemicals, then you're dabbling in things that are not yet known. And what you don't want to be is the person that ends up being written up as a case study going, this gentleman did this with this and this happened. Because yes, it will contribute to the scientific literature, but it will be at your detriment. So I would not recommend looking at SARMs to treat things. I would discuss with a clinician who's well versed in looking after those such things, like a urologist.
Of course. Yeah. Typical dose. Is it common to have excessive hair fall or shedding just 2 months after starting TRT? I'm on 120 cypionate split 3 times a week.
Okay, yeah. So this is if you're getting hair shedding that early on, then you're genetically predisposed to male pattern baldness. So you're seeing the increase in DHT, and your androgen receptor density is high in your scalp. If your hair is important to you to the point where you're willing to maybe have it impact the efficacy of your TRT, you could talk about things like 5-alpha reductase blockers, like dutasteride and finasteride. I wouldn't recommend it myself personally, just purely because I've seen it have quite negative outcomes for some guys. And I don't think your hair is ever as important as how your quality of life is ongoing, because you can have a perfectly happy life without hair. And if it's a part of your identity, then and you feel that strongly about it, and maybe have a chat with your provider about blockers like finasteride and dutasteride. But I personally wouldn't recommend them. It's if you're getting shedding that quickly, then you do have the genetic polymorphism for male pattern baldness.
My 1 milliliter cypionate vial says single dose on it, but that will be wasting medication for me. Is it okay to use a single dose vial 2 or 3 times?
Yeah, so so we covered this a little bit earlier on, didn't I? I wouldn't keep the glass ampule snapped and open, because anything is getting into that, and even if you try as you might to try and cover it, it won't be effective. So you're increasing the likelihood of, at the very least, localized cellulitis at your injection sites, and at the very worst, sepsis. So what I would recommend is transferring it into a multi-use vial. So if you don't want to waste things, because these are sterile medical grade glass vials that you should be able to get through your provider, and then you can transfer it into there using an aseptic non-touch technique. If you just Google that, you'll see that on YouTube, and then you can use your medication and not waste it.
Yeah. Another question I had earlier on, and there's one more coming in. We're almost at the 1 hour mark, but what is the highest dose of TRT that you ever saw patients take to be optimized? Because I've heard about 300 milligrams to be all right, and less wasn't alleviating any symptoms, but what's the highest you heard?
Yeah, so the highest I've seen is 250. So, and this is an interesting topic. So I'll just quickly touch on it because I actually was chatting with Dr. Winge about this. So there's so much we don't know about why different people require different doses to reach certain numbers. Because you can take two guys with the same body habitus, same fitness routine, same age, looking basically identical. One of them needs 100 milligrams a week, and the other needs 300, and they get the same total and free testosterone. And there's actually some literature about this, and it's to do with genetic polymorphisms in something called phosphodiesterase type 7b. And there's a specific gene that affects how we break down the ester on testosterone. And if you're lacking in that, then you don't break down the ester very well, and you don't get as much of the T, so you need a higher dose. So, and there's other things as well that can impact that. But that's a particularly interesting one where they looked specifically at guys that were almost identical in their circumstances, but required vastly different doses to get the same numbers. So yeah, it's that's a reason why you might need a higher dose. And certainly I've not seen anything above 250 in the UK.
Which lab values are most important to follow up upon after starting TRT?
Yeah, so you're going to want to. I like to look at the big picture because our hormone profile isn't just our hormone profile; it's impacted by multiple other things. So our liver function affects our SHBG synthesis, so that impacts our hormone profile. So I'll look at liver function. I'll look at lipid profile. So I'll want to look at the split between low density lipoproteins and high density lipoproteins and triglycerides. And I'll want to look at your full blood count as well, especially if you've got a background in cardiac failure, and I've started you on TRT or congestive heart failure, things like that, or any heart condition that you take medication for. But in general, I think it's a good idea to keep an eye on your FBC, because that's the first sort of marker where you'll see raised hematocrit, which again, I don't worry too much about. If you want to know more about that, go back in the video. We talked about that already. But it's just good to have an awareness of that, because the last thing you would want is for someone to have any kind of deleterious cardiovascular event 10 years down the line, and then someone scrutinize your paperwork and say, oh, they had a hematocrit of 0.61 10 years ago, and you're like, and it's like, yeah, so, but it's good to be able to prove your due diligence. So full blood count, or you call it CBC in the States, complete blood count, liver function testing. Thyroid is super important. Like, I can't believe I haven't touched on this already. But yeah, thyroid function and TRT, they need to be looked at together, because there's often either dysregulation in the thyroid before, or it can occur after you've been on TRT. The mechanisms by which are not really fully understood, but it's something that can be optimized, and it can be the difference between feeling great and feeling terrible on TRT. So yeah, thyroid function is something that I'll check, and I actually our clinic have a very comprehensive thyroid function check. I offer the basic ones as well, but if I see anomalies, then I will ensure that patients get reverse T3 looked at, for example, TPO antibodies, stuff like that, rule out Hashimoto's. So yeah, thyroid function is extremely important. But yeah, and then other than that, just all your regular annual blood tests for the aging male.
Another question we already touched upon. If you don't want to waste the testosterone in the 1 milliliter glass ampule, could you just preload the syringes? And if so, how long would it be good? So we already answered that. Yeah. We prefer that you put it in a 1 cc glass vial, because the rubber stoppers in the syringes will dissolve. So that we already talked about that.
There is one way you can do it, and that's using silicone plunger syringes. And I've done a test with those, and they last over 8 months. So, and they don't degrade, but they are exceptionally expensive. So yeah, it would
maybe better to throw away the waste of the.
It wouldn't be. Yeah, it wouldn't be cost effective.
Yeah. John Pistilli, thank you for being a channel member. You can see that at the nice badge. Greetings back. He says, I'm switched from weekly injections to the pellets inserted every 4 to 5 months. Been doing this for the past year, was having blood pressure concerns. Numbers look better, but still lack the energy I felt with the injections. Is this all in my head? What other tests should I ask my provider for?
So I mean, that's a big can of worms, that one. So yeah, it's difficult to comment without knowing his medical background, and I might add that anything I say on here is not to be considered as medical advice. You should seek the advice of your provider. But yeah, so there could be absorption issues. There could be distribution issues because it's an indwelling pellet. So you're definitely, I think, going to have felt better on injections because you can manipulate the dose with precision, and you're gonna have a reliable method of absorption. So when we think about pharmacokinetics, we think about absorption, distribution, and then we think about elimination as well. And you can't reliably predict that with implantable devices. You see this in female HRT as well. They often have implantable devices, and some women get on great with them. Some of them have absolutely horrendous outcomes. And that's because there's a lack of predictability of how you absorb and metabolize and excrete the drug that it's impregnated with. So yeah, I think without knowing your other lifestyle circumstances, because it may be other things, it might be that the test pellets are doing a great job, but you maybe need to look at other areas of your life. You might need to look at decreasing alcohol, increasing exercise, improving diet, for example.
Do you stop your patients TRT or force them to donate blood if hematocrit is over 54% or hemoglobin is about 180?
Yeah, no, we talked about this earlier as well, didn't we? Yeah, secondary erythrocytosis to TRT is not a concern. It may give you transitory symptoms of fatigue or slight breathlessness, but if it's not causing hypertension and you don't have any significant comorbidities like cardiac issues, then it's not something you need to be too concerned about. And I certainly don't force anybody to donate unless, of course, they have clinical symptoms and a cardiac background. And then I might look at the risk versus benefits, but I certainly wouldn't jump to it.
Sure. My lab numbers and symptoms are good on only 60 milligrams per week. Is that a not low amount?
Yeah, it's that is low, isn't it? Yeah, so that probably tells me that this person it has that genetic polymorphism we were talking about, but they have a lot of that enzyme, so they cleave it very efficiently, and therefore they don't require a lot. As long as you're feeling good, then and you're not having any negative effects, then yeah, stick with it.
Sure. Do you have any recommendations on HCG shelf life for low dose administration, 900 IUs per week?
Yeah, so you've really got to follow the manufacturer's device, and it depends what you've reconstituted it in. So it's most stable at for about, well, according to manufacturers, and I'm specifically talking about a brand called Ganassi here. It's most stable, or all HCG is most stable when it's reconstituted with something called bacteriostatic saline. And that's something that's had sort of treatment to the saline itself to ensure that there is absolutely no way that there can be any contamination from bacteria, and it increases the stability of the saline so that you can keep it for reconstituted for 30 days as long as it's kept in the fridge. So, Ganassi itself as a powder before it's reconstituted can be stored at room temperature. But as soon as you add bacteriostatic saline, it's got to go in the fridge and stay there. And then you take your dosage out each day. But yeah, it's different for different brands. And if you've made it up with, water for injections, it's only stable for 7 days. So yeah, bacteriostatic saline is the way to go.
Matt Mason said, I too am an ester clearing machine. Lee Aris asks, I'm getting anxious and a heart rate at night. Will pregnenolone help?
Yeah, well, the answer is maybe there. Again, I don't know this guy's medical background. But yeah, you do get there is that sort of theoretical thing, isn't there, about neurosteroidal suppression when you're on TRT. with pregnenolone being an allosteric regulator for progesterone, then yes, progesterone has a calming effect on us mentally, as it does for female patients as well. So yeah, you may benefit from that, but I think it's probably something best discussed with your provider, because they know what your other medical background is, what meds you're on, and they know your medical history. It may be that I don't know, I'm not casting aspersions, but you may have had a background of anxiety in the first place. So it's something that when I see a lot in my patients, and it's something I always inquire about, any history of anxiety or antidepressant use, because that can be something that is triggered again once you start TRT, and then you think that everything that happens is due to the TRT, when actually it's not. It's your mental state that's haunting you, and is something that perhaps needs addressing. Not always through medication either, just CBT, talking therapy, that can always help.
If I feel better when using HCG, when adding it to my protocol, is this because it increases my testosterone? Would it be better to increase my TRT dose then?
Yeah, so that's a difficult one to answer. So it may be that the neurosteroidal backfilling, or if you want to call it that's again a bit of a topic of debate, isn't it? It may be that it is having that function for you, and that's why you feel better. But it also may be the increased intratesticular testosterone production. It might be preventing testicular atrophy, and that makes you feel better. It's a difficult one to answer. The only way you could do that is by negotiating with your providers to say, could we perhaps have a trial of TRT monotherapy, and then to allow for the lack of intratesticular testosterone production through the stimulation of the Leydig cells from the HCG, can we increase my dose, and see how you go?
Right. Okay, so let's round it up, Felix. If people in the UK want to work with you, how to contact you?
Yeah, so if you go to our website, www.healand.co.uk, as spelt on my avatar just here, or you can find us across all social media platforms. We are at Healand Clinic. If you check out our YouTube channel and like and subscribe, I'd be grateful. And we're trying to really push our TikTok channel at the moment because it's not doing too well. So head over there and you'll see that I do regular hormonal health shorts for both men and women. I try to do those as frequently as possible. And you can check out our Facebook page. That's Healand Clinic as well.
Yeah, right. So I don't visit TikTok anymore. It's Chinese spionage.
Yeah. Yeah, true. Yeah, there's definitely some thought around that, isn't there?
All right, so the links to your socials will be in the description of this video.
Fantastic.
Thank you so much, viewers. Thank you so much, Felix, for doing this, and talk to you next time.
Thank you very much for having me, Dr. Devos. Take care, everyone.
You're welcome. Bye-bye.